To open the next session, please welcome Dr. Tae You Kim, AOS Council member and professor at the Department of Internal Medicine, Seoul National University College of Medicine. He is the director of the Center for Precision Medicine at Seoul National University Hospital and chairman of the board of directors of the Korean Society of Medical Oncology. He is the co-founder of IMB Diagnostics Incorporated, which investigates blood-based monitoring and detection of cancer. His research interests include cancer genome analysis, chromatin and DNA methylation during carcinogenesis, and development of molecular targeted cancer therapy. Please welcome Dr. Tae You Kim.
Good evening, ladies and gentlemen. The next lecture is entitled Tyrosine Kinase Inhibitors in CML. The 10-year survival experience. Our distinguished speaker is Dr. Zeba Aziz, an AOS board member and the Dean of Medical Oncology, College of Physicians and Surgeons, Pakistan. She is the head of the Department of Medical Oncology and Program Director of Medical Oncology Fellowship at Hamid Latif Hospital, President of the Society of Medical Oncology Pakistan, and a member of the Steering Committee for the Australian and Asia-Pacific Oncology Research Development Accord Workshop. Ladies and gentlemen, please welcome Dr. Zeba Aziz.
I'm Professor Zeba Aziz, Head of Department Medical Oncology, Hamid Latif Hospital. I'd like to thank the organizers of Asian Oncology Society for inviting me to give a presentation on role of tyrosine kinase inhibitors in chronic myeloid leukemia, a journey which we faced many challenges and many fruitful associations. With the introduction of tyrosine kinase inhibitors for treatment of chronic myeloid leukemia, the treatment outcomes and survival have improved tremendously. The IRIS study on a 10-year estimated overall survival showed that the 83.3% patients were alive who had achieved a complete cytogenetic response. Patients who achieve a deep molecular response have a survival comparable to that of age-matched controls. In developing countries, the availability of TKIs through patient access programs have revolutionized the treatment of chronic myeloid leukemia. What we are going to look at is the cytogenetic responses with TKIs, survival outcomes, quality of life, pregnancy outcomes, and treatment-free remission. We published our first paper in Cancer 2007 on treatment of chronic myeloid leukemia in imatinib area. We took 275 patients with all disease phases who were diagnosed within 18 months of diagnosis of chronic myeloid leukemia. The initial starting dose was 400 milligrams, which was increased to 600 and 800 milligrams depending on the cytogenetic response. The primary endpoint of our study was complete and major cytogenetic responses. Secondary endpoints included complete hematological response, time to progression, overall survival, and we divided the patients into early and late chronic phase. Late chronic phase included patients who came 6 months after their diagnosis and were already on hydroxyurea. When we looked at the patient characteristics, what was striking was that the median age of our patients, along with other developing countries, was about 35 years. The majority of patients had a low so-called score or an intermediate so-called score, and the major mode of diagnosis at that time was by 922 translocation on the bone marrow, that is the Philadelphia chromosome. Over 40% of patients had been treated with hydroxyurea previously. What was the response of imatinib on these patients? What we found was that the patients who had been treated previously with hydroxyurea or came late to us had a lower response, complete and partial cytogenetic response compared to newly diagnosed patients who were over 70% of them achieved a complete or major cytogenetic response. Patients who had a lower so-called score also or intermediate also had a higher complete and partial cytogenetic response. And when we looked at the time to progression according to cytogenetic response, we found that patients who had a complete cytogenetic response, over 90% were projected to be alive at 5 years, while those who did not had a lower 5-year time to progression. The overall survival rate of our patients was projected to be 80%. This is the survival curve of patients in chronic phase, accelerated phase, and blast crisis. The chronic phase patients were over 80% were projected to be alive compared to less than 40% in the blast crisis. Uh, these are the toxicities according to imatinib. And what we found was that in the chronic phase, there were hardly any toxicities, but there were more grade 3 and 4 toxicities in accelerated and blast phase. And we related this to the younger age of our patients. The conclusion from this study was that the median age of our population was much younger. Uh, and this is true for all developing countries. We achieved a complete cytogenetic response in more than 50% of our patients with chronic phase CML with superior long-term survivals. Patients who were newly diagnosed and had a lower so-called score had a better responses than patients who came in late with a higher so-called score. We had few toxicities, and since it was a patient access program where payment did not have to be made, the compliances were very good and patients tolerated their treatment well. We then looked at sustained superior long-term outcomes and cytogenetic responses in only chronic phase, and this we published in the Journal of Clinical Oncology in Japan. We looked at the survival outcomes in patients at 48 months. The primary outcome this time was event-free survival. And again, the secondary or endpoints were similar to what we had studied previously. Here, I'm showing you the patient characteristics according to the cytogenetic responses, complete cytogenetic response. And what we found was in younger patients less than 50 years, the cytogenetic responses were much higher than older patients. We also saw at the same time that the complete cytogenetic response in early phase of the disease was much higher than when patients presented late in the chronic phase. Again, so-called SOR was associated with complete cytogenetic responses. And this is the projected event-free survival at 16 months. And we've divided it. One shows early chronic phase disease, and you find that the event-free survival in patients who achieved a complete cytogenetic response was about 80%. Over 80% compared to no cytogenetic response. Similarly, event-free survival was also 92% in patients with lower so-called score. When we looked at panel B, which is late chronic phase, again, the event-free survival was 93% versus 53% in patients with no cytogenetic response. And it was much higher with the lower so-called score. This is event-free survival, early versus late, related to CML events and all events. And what we found was that event-free survival, if you achieved a cytogenetic response, was similar. The CML deaths were higher in the late chronic phase compared to early chronic phase. And the Cox regression analysis for event-free survival showed that, again, age was important. Achievement of complete cytogenetic response was important. So was the so-called score. The hematological and clinical response were important, but for event, p-value was not significant. These are again the drug-related toxicities, which were not grade 3 and 4 toxicities were not very common, and patients tolerated the treatment well. We concluded from this paper was that in the intent to treat, the projected event-free survival and overall survival were 79% and 86% at 60 months. Complete cytogenetic response was 67%. Achievement of lower complete cytogenetic responses were related to inclusion of late chronic phase disease, which was 50%. We did not notice any intolerance to imatinib, probably related to young age. We then looked at the quality of life with imatinib because this is a long-term treatment. And when a disease is common, we have to look at the impact of the drug not only on survival, but also on the quality of life. Whenever we give chronic treatment, long-term consequences which have to be studied included include physical and functional impairment, disruption of social and family interactions, psychological distress, and we have to look at the benefit gained by increase in survival, along with the negative impact of side effects. The quality of life provides a unique information from patient's perspective, and it is important in our part of the world as majority of our patients are less than 40 years. What we did was we took 90 newly diagnosed patients and evaluated the quality of life at enrollment at 3 months and 6 months. We used the FACT BRM version, and the primary endpoint was trial outcome index. We used 4 subscales: daily functioning and well-being, fatigue, emotional and cognitive function. We took median age of our patients was 30 years, 38 years. Low so-called score and intermediate so-called score was present in over 61 persons. We looked at the performance status at baseline, and we found that 57% of our patients had a performance status of greater than 3. However, after 3 months, their performance status improved to 1 and 2 in about 98% of our patients. This is the trial outcome index at baseline, 3 months and 6 months. As I mentioned previously, we looked at daily functioning well-being, we looked at emotional and cognitive function, fatigue, and side effects. What you could see is that the difference in the values shows that they were highly significant when we treated all our patients with imatinib. And this is the visual presentation of the mean improvement. You can see that the daily functioning and well-being improved significantly, the fatigue decreased, and the emotional and cognitive function also improved. Side effects of the drug were not significant. So what we concluded from this study was that clinically significant improvement in the quality of life was seen in the first 6 months of the patient. This effect was independent of age, so-called score, sex, and performance status. And due to clearly improved quality of life, patients had a high rate of compliance. Lastly, we also looked at pregnancy outcome in patients with chronic myeloid leukemia. We know that our patients are younger and they need to get pregnant when they want to. So we looked at 89 patients, 40 males and 21 females. And I'm going to concentrate more on the females who had 27 conceptions. Pregnancy outcomes are limited and the potential impact of imatinib on the baby is not known. At that time, even now, due to lack of sufficient information, conception is advised. And the two major problems we face when we treat any patient is that the mother needs optimal therapy, and the fetus may be affected by may be affected by the disease, and the teratogenicity of the neoplastic agent. So since it was about 4 years, and complete hematological responses were genetic response. We had one patient who had, and basically when you look at this cytogenetic responses, 12 patients 12 female patients discontinued imatinib. And what happened was only one patient lost her cytogenetic response, complete cytogenetic response. 9 patients did not discontinue imatinib. And of these, despite explaining several times that you should, they did not. And 2 patients, the cytogenetic response improved to 5 patients who did not because they continued imatinib. So the conclusion was there were spontaneous stillbirths, there were abortion rates also, but 80% of our population delivered normally. Pregnancy is frequent. Pregnancy was continued in our patients because they were precious pregnancies due to family pressures, societal issues, and they were also scared that if they stopped imatinib, their access program will stop, and religious issues where they did not want to get aborted. So 80% of our patients delivered normally, and in the females, all the patients had normal deliveries. We now looked at patients, since this presentation was due, we decided to look at patients from 2014 to 2019 to see what is the difference between 2001 and 10 years, a decade later. Here we looked at nearly 700 patients. We found that the median age is still 38. We also found that lower SOCAL score was common, and chronic phase was now 95% instead of accelerated in blast crisis. The things that changed was that the diagnostic test performed more frequently was FISH testing and PCR. Cytogenetics were less common. First-line TKIs were distributed between imatinib and nilotinib, and imatinib was, not the only drug which was being used. The dose escalation or change was not related to progressive disease by itself into accelerated or blast crisis, but no response seen on FISH by FISH or PCR when the dose was changed. The compliance was good for first line therapies, and 97% of patients are still alive, and loss to follow up was hardly any. So basically, we have younger, same age of patients, diagnostics have changed, treatment options have changed, and the way physicians are approaching treatment have changed slightly. This is the projected overall survival on dose escalation, which is over 90%. And the sex of the patient does not make a difference. 98% of our patients are alive. This is a projected 5-year survival either with nilotinib or imatinib, and it does not make, there is no difference. Overall survival is seen in about 98% of our patients, and this is projected overall survival. We then presented this poster at ASCO Asia and basically looked at the cost effectiveness of treatment-free remission in chronic myeloid leukemia. And what I'm going to show you the current results. We have 20 patients, 25 patients were eligible, 5 withdrew consent, and 10 lost their MR 4.5 and were restarted on imatinib. Currently, we have 10 patients who are between 28 to 31 months of their TFR. The financial implications for these 10 patients are that we have saved approximately $1.4 million. And you can see the table of patients who are going through, and they are very stable. Now, majority of the patients do not want to go into TFR or take the chances because they're getting free drug, which is becoming a major problem for us. So what are the lessons we have learned? The patient access program and Novartis have given extended patient and physician education. This has resulted in early patient referrals, improved diagnostic efficacy, and molecular testing is being used increasingly. What are the challenges which we face in developing countries? Compliance is an issue. It is not compliance alone by the patient, but also by the drug company, because sometimes due to customs or whatever reasons, the drug may not be available and patients may go without a month, 2 weeks, 3 weeks without the drug. Treatment-free remission is not being embraced by the patients because they're scared, and the drug is free, so they don't want to take a chance with this. Using molecular testing according to guidelines. Molecular testing is being used increasingly, but it depends on the affordability of the patient. And we are not following the ELN guidelines regularly, as mentioned in the ELN. So that is why we are having problem. The molecular testing is done when the patient has money. And that is what the challenges we face, which we have to improve. Thank you very much.
Okay, so thank you, Dr. Aziz, for your nice lecture. And also thank you very much for sharing your experience with us. So now, from now, we are going to have the live Q&A. Okay, so I will give you a couple of questions first. So compared to the Western CML, is there any characteristic in Asian CML patient?
Yeah, I think so. That we have younger patients, more healthier patients,
And basically, they tolerate imatinib and nilotinib pretty well. And the intolerance is less. The only problem is, which which I don't think is too much, is that if they don't take their drugs regularly, and the drugs which are not taken regularly are dependent when Novartis cannot supply us the drug, and the patients are so poor they can't afford to buy the drug. So basically, you are looking at 8 to 10 weeks a year where the drug is not provided for either by the government or by Novartis. So that is where the problem is. But otherwise, the other major thing is that this is a population where they want to produce children, and the kids because of the society pressure, because they want to have them, and as a result of which we have some problems trying to convince them either not to have them or to have them once they have spoken to us, so that we can monitor them closely when they're off imatinib, and that they should be taking it for at least until they are in a deep molecular response before they try to get pregnant.
Okay, thank you. And so the imatinib is the first anti-cancer agent which is the effective in CML. So this drug is still the treatment of choice in treating the CML chronic phase. I understand there are many the second or third generation the BCR-ABL inhibitors.
See, we do have nilotinib here, which are the two drugs which are approved in Pakistan. Now, the problem with nilotinib is that because it's being provided free by Novartis, about what we've seen in the last 5 years is that 40% of newly diagnosed patients are put on nilotinib. Couple of reasons which are genuine include uh, uh, high so-called score, or these are younger patients who want to get off the drug after 5 years and want to go into deep molecular response. But the other thing is that some of the doctors are just putting nilotinib because they feel that maybe this is a better drug, even though there's no survival advantage. However, you can see that the molecular response is deeper. So I feel that it is being overprescribed in part of the by some doctors, and you can just start on imatinib if needed. But that is the way it is, and there's nothing we can do to change it, because there's also a concern that Novartis might stop producing imatinib, and then the free drug will not be available for the patients.
So the nilotinib is available in all the Asian country? Okay.
Yeah.
Thank you.
Both of them are free of cost. And
Okay.
basically, the patient does not have to pay anything. Novartis pays for 9 months of the drug, and the government pays for 3 months.
Okay. So far we don't have any question from our participants. So, okay. So you mentioned the TFR, the treatment-free the remission. So TFR, okay. So how long TFR is maintained, then you can say it is cured. Is there any definition of TFR in terms of cure or something?
We have a few patients who are out at 36 months. But basically, we have very few patients. And the reason is that some of the patients who qualify for TFR are reluctant to go on it because imatinib or nilotinib is provided for free. And the patients don't want to leave the drug. So it's been difficult to convince the patients, but whosoever they are, they're doing pretty well. It's about 50% in our patient population. And the last patient is around 10 months out. So I think hopefully a couple of, if these 50% of patients will be able to achieve their TFR. Is it curable? I don't know. We will see the literature which is available all over the world. And if they're cured, they're cured. That is the best part of it. They're off the drug for a while.
Okay. Okay. Okay, I think there is no question from our participants. So I'd like to thank Dr. Aziz again for your lecture.
Welcome.
Thank you. And
Thank
also,
you.
I'd like to close this session.
Okay.
Thank you very much.
Bye-bye.